you all for this wonderful crafted scientific program, especially on a topic of neurogenic bladder, which is not very commonly discussed and not very clear cut understood by the patient and the doctors. So the various aspects about the diagnosis and the management of this focused topic by our expert, Dr. Gopal Badlani, a very senior expert on this field since so many years of experience. I'm sure that all of us would be wiser at the end of this program on this particular topic. I welcome you all. Good to
I think he's not
welcome
audible.
to you. Thank you.
Hello.
Yeah, thank you very much, sir. I request our Honorary Secretary, Professor Dr. Uttam Mete to say a few words. Hello, sir. We can hear you, sir.
Hello.
Hello, Dr. Uttam.
We can hear you. We can hear you, sir.
Navneet,
sir doesn't seem to be here, sir. Perhaps he is disconnected.
sir?
I think I'm off.
Yeah, I think you can log in once again, sir. I've told Navneet, yeah.
Just log in.
Yeah.
It is from the portal.
Okay, sir. Just try, sir.
So I'm just logging in. Hello.
Yeah, yes, sir.
Am I audible?
Sir, you are logged into my mobile.
Yeah, but
Yeah, I'm just trying. Navneet, can you just check with Dr. Uttam?
now see, am I audible?
Yeah, we can hear you now.
Am I audible?
Yeah, sure.
Okay.
You are visible and audible.
President has so Dr. Lalisa sir has finished his welcome address.
Yes.
So can I start now?
Yes, please.
Waiting for your comments, sir.
Okay.
Yeah, sure.
Okay. So good evening, everybody, and thank you, ISU USI, for this webinar. As USI Secretary, it is my proud privilege to welcome you all and to join this theme-based webinar. And the theme of this webinar is neurogenic bladder. As you all know, that neurogenic bladder means the bladder dysfunction due to underlying neurological cause. And I don't have any hesitation to say that when I was a student also,
I think we have some audio issues with Dr. Uttam. Ma'am, what shall we do?
Shall I try calling him? Otherwise, you can start, and whenever he joins,
Yeah, because he's in a different place. So I think he has some issues with his net connection.
Okay, I think you can proceed by introducing sir.
Yes.
I'll try and calling him. I'll try to call him.
So actually, we don't need any special introduction of Professor Gopal Badlani. Sir is a very well-known figure in AUA, not only in AUA, but in Indian neurological circles. Sir is a professor and vice chair at Wake Forest University, North Carolina. He is the current course director for female pelvic health and FPM-RS fellowship. Sir is an excellent teacher, excellent surgeon, and he has excellent organizational skills which was seen during his Secretary Generalship of AUA and in managing Endorological Society. He is involved in a lot of voluntary work, and he is a recipient of Dr. B.C. Roy Medal from President of India. Sir, over to you.
Thank you very much. It's always a pleasure to share time with you all. My goal today is to discuss the bladder dysfunction occurs in neuropathic patients. Most importantly, recognize the risk factors that occur in neurogenic bladder and perhaps manage our patients with neurogenic bladder. It's not a lecture on neurogenic bladder, which I've done before through your other meetings, and I believe even last in the Gurukul. So today is sort of meandering through different cases and learning certain points. So it will not cover every aspect of neurogenic bladder, but representative cases, and then hopefully we can bring some salient points. I'm okay to be interrupted with any questions at any time. Just either raise your hands or put a chat that somebody, maybe Dr. Vishwarup, can monitor. If there is a question, I'm glad to answer it. I may not be able to see your hand. So we start off with some pre-seminar questions. So here's the first question, and I believe Dr. Vishwarup said he has 2 opening batters. So maybe either who's the Jaiswal and who's the Rohit Sharma of this team?
Just we have Dr. Kashi, Dr. Ashwath, Dr. Harsha, Dr. Agastya. I think all of them can actually put their videos on and the audio on, and please answer the questions.
So pick one of them. Pick one of
rest
them.
of the residents can put the questions in the chat box.
Yeah, that is the correct answer, and we'll go through why others are important or not important. So whoever is the next batter.
Dr. Ashwath.
That was a rover activity.
My God, I won't have anything to teach today. Third.
Kashi, you can take it.
It's a poorly worded question, and that's why it's confusing.
Just T diagnosed with AMG rather than CMG.
Correct. Okay.
D Betanacol.
Very good. Okay. All right. So we're going to start with a case scenario. We have a 53-year-old male who has MS for several years. He's in a wheelchair, transfers with assistance and partial ability for activities of daily living. Now, the point here is when you have a patient with a neurogenic bladder, it's not the bladder you're thinking about or their symptoms. When evaluating them, their ability to move, their ability to use their hands, it becomes very particularly important. And as you'll see in this case, so he has right-sided weakness, which is again not typical of MS, unilateral weakness. He has voiding difficulty from the very beginning, initially treated with alpha blocker, which is a reflex reaction for every male that comes with voiding dysfunction. He stopped the medication after he had an MI. Recently, an episode of retention, was treated with a Foley, which got pulled out into the urethra, requiring a replacement of a cath. He was hospitalized. His cath is out for a few months now. He's back on Flomax. His primary complaint at the time of presentation was bilateral testicular pain, 5 days duration, no fever, voiding is okay post-void residual is 0. He's on pain medication. He had a scrotal ultrasound which showed left-sided epididymitis. Any questions thus far in terms of his history? We can go further. Now, this is the report of his flow rate. I would like one of you to comment on his flow rate. As I said, the PVR is 0. Kashi or Ashwath?
Ashwath.
There, by the way, there is no trick questions here, okay? So don't look so worried. Take that worried look off your face, Ashwath. You look like very tense in an exam. You're not. All right? So what do you think of his voided volume is 280, his peak flow is 22, his PVR is 0? Sound normal to you?
Sounds representative. Sounds representative.
Yeah, so point here is don't rely on the numbers, because peak flow can come from Valsalva pushing. So let's look at his flow pattern. Now, what do you think?
This is abdominal straining, sir. And
What's the differential in abdominal straining with his history?
history of MS, but there is history of catheter being pulled out into the urethra.
Yes. So you said this part could be Valsalva voiding, right? This
Yes.
versus what else? What else could cause a pattern? Forget this part for a minute. If the voiding was just like this, what would you think about? Alternate differential diagnosis to Valsalva. Okay, now tell me if you think of a differential diagnosis. What is happening here?
Detrusor overactivity is there, sir.
With?
EST, sir.
Right.
With the sphincter dyssynergy.
So now if I go back, differential diagnosis here is Valsalva voiding or DSD, correct?
Yes,
You
sir.
can't just tell from the flow without this.
Correct.
Now, the characteristic of DSD is to be established. First is looking at the detrusor contraction. When you're studying urodynamics, my way of assessing urodynamics is first look at the technical aspects, right? I cough, my lines are balanced, right? There are some motions in the rectal, which could be rectal contractions or breathing. But the line at the beginning or the end is matched, is what I look for. Okay, you see the cough line here. So the study is valid, right? So here is first sensation, and the bladder is already contracting. That reflects bladder overactivity, correct?
Yes, sir.
Okay, and then the bladder is now. The question here is whether this part here is volitional, that means I'm guarding during the study, versus a true dysenergia, right?
Yes, sir.
Typical spinal cord dysenergia, the key point to remember is that bladder, before the bladder contracts, the EMG will increase in a typical dysenergia. Whereas if the contraction comes after the bladder has already started, it can be due to guarding. Now, how do I know this is not guarding or volitional? I look at the abdominal line, right? Typically, if you're trying to strain, your abdominal pressure will also go up. So if there is no movement in the abdominal line and the pelvic floor is firing, it is not volitional, right? Subtle ways of telling different things. There is clearly no clear-cut way of knowing. Here, you see that typical pattern as I was telling you, before the contraction, right?
Yes, sir.
So overall, if I look at his flow pattern, history of retention, and this pattern, my diagnosis is he has DO with
Yes.
EST, right? Now, how do you manage that? Do you rely on the fact that he voided with a PVR of 0? Is that good enough, or should we tell him stop pushing and argue, straining, rather than treat him with CIC with anticholinergics? Okay, that would be the most typical first step management, along with some fluid management would be his management. Right. Now, in his case, there is other option. If he cannot take anticholinergic or is not good enough, that we would inject Botox today, right? That would be the easiest way to manage him. Now, you remember his history? Before we go on to that, there is some debate whether neuromodulation or can be used in MS patients to modulate the bladder behavior. Previously, in the first version of the neuromodulation, it was not a good choice because these patients need MRI all the time. And once the device was in, doing MRI was a contraindication. But now the most current devices are MRI compatible. So there is a trend to use neuromodulation in MS patients, not a large experience as yet to be able to say as a standard of treatment. The guidelines don't mention the use of neuromodulation. Now, in his case, in his history, what was significant was his right-sided weakness, right?
Yes, sir.
So he's unable to do CIC. So now what's his option?
Suprapubic catheter, sir.
Correct. So suprapubic tube with Botox. Because, as you see, he had a suprapubic catheter that was draining well. However, he had 2 symptomatic UTIs and also persistent discomfort with pain and discomfort in the penis. And he had antibiotics and oxybutynin, which was still not working. So one thing you got to remember, as patients with complaint of these problems, we are leaking still with suprapubic tube, you need to paralyze the bladder further. You need to inject Botox to see if that will go away. Now, what is the effect of DO can get worse with the suprapubic tube because of the foreign body effect. So you have to think about it. And in a male, DSD relates to this problem of recurrent epididymitis or infections. Because what happens is the bladder is trying to go, the external sphincter closes, and the urine refluxes into the prostatic ducts and or through the ejaculatory ducts into the epididymis. This is also one of the mechanisms where the so-called patients with prostatitis, which in my word doesn't exist, push a lot to urinate and then results in epididymitis. So Valsalva voiding also leads to the same phenomena. When you bear down, your pelvic floor tightens and the urine can reflux back into the ducts and or prostatic ducts, and they develop these symptoms which are ended up being termed prostatitis. Flow pattern or UDS or doing PSA is a good way to completely rule out prostate as the culprit, right? PSA is one thing that you can always do whoever presents to you as prostatitis. If the PSA is normal, the problem is pelvic floor, not the prostate. So digressing from this patient. So that's currently management. Now, before we go on to the next patient, any questions or any queries before I proceed further?
So how much Botox would you inject at one time, and what is the frequency of repeat or the second or the third injection in
So
this
you
case?
maximize the dose in a neuropathic patient who's going to be on a catheter drainage as opposed to a idiopathic bladder overactivity where you're relying on their voiding normally. So in neuropathic patients, 200 to 300 units of Botox is what we inject. And typically we reschedule the patient in 6 months. Some patients will last 4 months. Some patients will last 8 months, rarely a year. So we let the patients judge when their symptoms are recurring. Sometimes if the symptoms come back, they rely on the oral medication to supplement the effect. to prolong the injection response. So most typically, a follow-up is scheduled 6 months.
Oh, okay, sir. And sir, won't we do any studies to rule out any trauma caused by that urethra by that catheter being pulled out? Like in addition to DSD, if something has happened.
Yes, that's a valid point in his case. Is if we were doing if the patient had to do CIC, it would be a requirement. In a patient where we did suprapubic, we automatically did a cysto while placing the suprapubic. So his cysto was done because our suprapubic tube placement technique is to visually place the suprapubic while you're looking in the bladder.
Okay, sir.
So there is a question
sir,
from the chat box.
Yes.
Is UDS and EMG enough for DSD? Role of video urodynamic study.
Yeah, so video is an additional assessment, which is key to separate out bladder neck function. So external sphincter overactivity can be picked up on EMG, most accurately with a needle EMG, which is what is done in spinal cord injury patient or insensate, not in a patient who has sensory intact. The EMG pads can have a lot of artifacts. So video urodynamics is helpful for a couple of things. In his case, it would be important to rule out reflux, which occurs sometime with high pressure and can cause the cause of sepsis. And the second thing would be if the bladder neck is opening or not. It is particularly important if you're going to choose a different form of treatment, which is most typically in a spinal cord injury patient where you want to consider doing a sphincterotomy to manage the patient with a condom catheter. So in a paraplegic, it would be uncommon, but in a quadriplegic patient who cannot do self-cath, condom catheter drainage with sphincterotomy will be an option as opposed to a suprapubic tube. So there, most typically, if the injury is at the sympathetic cord level, T8 to L1, video urodynamics is critical to make sure the bladder neck is opening or not opening with the bladder contraction. If it's not opening, then sphincterotomy needs to include bladder neck as well as external sphincter. So a very detailed answer to the question that was raised. For standard upper motor neuron lesion, such as MS or spinal cord injury level below L1 or above T7, CMG, EMG is adequate to confirm the diagnosis of bladder sphincter dyssynergia. Video is an additional assessment for reflux and or bladder neck assessment. Okay?
Yes, I think no more questions regarding this.
Right.
There was one
question. Person has persistent infection and or bothersome, consider doing TRUS to rule out prosthetic abscess or something else. Bladder stone is a common finding in patients with chronic suprapubic tube. You need to show them how to irrigate the bladder actively. We must follow up imaging with sono to rule out hydronephrosis, which occurs with gradually thickening bladder and poor compliance with the bladder. So monitoring this patient, we would see him every 6 months to a year with a screening imaging with a hydro and based on the symptoms, non-contrast CT to rule out any stones in the bladder or anything like that. Okay, talking about DSD and autonomic dysreflexia.
Tachycardia.
That is correct. Bradycardia is the symptom. All right, let's just recapitulate the neurophysiology just as a memory test. we have the peripheral nerves, which are from sympathetic pathway, which primarily work on the outlet and the bladder body, the beta sympathetic and alpha sympathetic here. And then you have the parasympathetic, which is both coming into the spinal cord and going out, which is relying on the contractility. The parasympathetic fibers and receptors go to a various degree down the urethra as well. And then you have the somatic component, which is the volitional component, which is the pudendal nerve. All of them is at the onus nucleus, S234, with S3 being the predominant nerve. Receptors are important in trying to pick your drugs to treat or block. So M2 and M3 receptors are the main receptors in the bladder. They are studied in a normal bladder, not so much in a neuropathic bladder. So some drugs will claim I'm a better M2, I'm a better M3. It's really not critically different clinically. Whereas alpha receptors, again, selective alpha 1, alpha 2, again, have not shown a clinical difference, but they do exist in the market. The beta 3 agonists have become the more newer drugs in terms of managing blood and are important in certain conditions where patients based on age and or neurological condition cannot take the anticholinergic medication. So muscarinic receptors and beta 3. So if you want to slow down the bladder, you need to give a beta agonist or anti-muscarinic drugs. Pelvic floor is nicotinic, as well as the alpha is in the bladder neck and proximal urethra, and that's why we give alpha blockers to reduce or alpha agonists to increase resistance in the passage. So a patient with bladder neck that's open and or mild stress incontinence, you can use an alpha stimulator. Unfortunately, there is no drug available, at least approved in the US, that does that, but off-label, you can use Sudafed or the SNRI drugs, which is duloxetine, which can be used to increase outlet resistance. Flomax, obviously, and all the alpha blockers in terms of reversing the process. Drugs that work on the skeletal muscle are rarely used in the urological world, which is baclofen and others. Not necessarily, it's not helpful in a DSD situation. So the side effects rely largely on the receptors in terms of where the contraction is occurring and relaxation is occurring. So you need to think about the transmitters and the drugs and rationally use the combination of medication. This is the side effect profile, the dry mouth that occurs, and the cardiac effects, the slowing down of the GI tract, constipation that occurs. All of this is related to the use of the muscarinic receptors. Whereas the beta 3 predominantly is a cardiac event that you need to think about in terms of drug. So autonomic nervous system controls the functionally, but it's involuntary, whereas somatic controls voluntary function, yet your bladder is fully under voluntary control because of the combination of the cortex, the spinal cord, and the pons. That's how it works. Regulation of maturation cycle is contraction, which is autonomic nervous system, whereas contraction of the pelvic floor is a volitional system. That means you can guard, you can tighten, you can relax the pelvic floor volitionally, whereas you can't do that to the bladder. So normal voiding consists of inhibiting the sympathetic somatic pathway so that the pelvic floor is relaxed as the first event. This is a very common question. What is the first event in the voiding cycle? The answer is pelvic floor relaxation. If you're doing a urodynamic study, you hear the EMG silence before the bladder contracts, and then activation of the pathways to be able to contract. There is control. This is Bradley's loop 1, which is cortical function through the intermediate to the pontine level. This is a pathway that is predominantly inhibitory. It is also facilitatory. That means you don't have any desire to urinate, and I ask you to give me a urine sample, you will be able to volitionally void and give me a sample most of the time. You're asked by your mother to go to the bathroom before you get in a car for a long distance drive, and most kids will say, I don't have to go, I don't have to go, I don't have to go, but the mother insists, and they go, and that's volitional. Whereas the bladder is being inhibited 23 hours, 55 minutes of the day by the cortical influence. If you interrupt the cortical influence, such as traumatic brain injury, CVA, MS, brain tumors, all of this will occur in the bladder becoming uninhibited, right? The bladder is also uninhibited if there is disruption here. What is the difference between a disruption here and a disruption here between the two conditions? Can one of you tell me?
So, sphincter,
The voiding is coordinated.
synergistic voiding will
However, voiding is, coordination is lost.
Person can take it.
Yeah, so you hardly ever need to do EMG in this group of patients. It's bladder overactivity without sphincter discoordination. Whereas here, and that is the difference between a newborn child and a spinal cord injury patient. Both void reflexly. Whereas the newborn child is coordinated, the spinal cord injury patient is not. All right? So loop 2 here, you have input from stretch receptors, input from C fibers, which are dormant most of the time, into the sacral cord, crossover and reaches the pontine micturition center, where reflex activity occurs, which is modulated by the cerebral cortex, right? So if you have an animal level behavior, a newborn, which is working at the pontine level, which is where the return occurs and the contraction of the bladder takes place, with letting go of the pelvic floor, which is from the motor cortex here, all right? So all this coordination is occurring within the 30 seconds that you void normally, and you take it for granted. So when we study the bladder, we fill the bladder, which is faster than our normal filling. You record the first sensation of voiding, which is early in certain conditions. Now, a bladder should not contract with the first sensation. You reach a point where there's normal desire, and typically you need to give permission for the patient to void. It's okay to go ahead and void. But if they can't hold, I mean, they reach this point and the bladder contracts without the permission, that it's still an uninhibited bladder, but at capacity, right? The difference between a contraction here and a contraction here is the fact that I can train this person to go by time, whereas this person will need some additional help with medication to postpone that contraction. Is that clear?
yes.
Small volume DO versus DO at capacity is a big difference in terms of management. And then the cycle begins again. All right, we've covered this, I think, all of this. All right, so pathophysiologically, you can separate out conditions simply by knowing what the neurological condition is and then predicting what the bladder behavior is going to be. Unfortunately, unlike the book, patient does not read the book, and a person with upper motor neuron lesion, take for example CVA, what's the most likely associated diagnosis with it?
Hypercontractile bladder.
That's an incorrect answer. That's not what I asked, first of all. That's a urodynamic finding. In a patient with, no, listen to my question. Listen to my question. A patient with cerebrovascular accident, what is the associated medical condition almost always present?
Spinal cord injuries.
क्यों ऐसा बोल रहे हो? Patient को stroke है, उसमें spinal cord injury कहाँ से आई?
Weakness,
No, what is the medical condition?
hypertension,
CAD,
And
hypertension.
hypertension is absolutely correct. One more.
diabetes,
Diabetes. All right. So now think about CVA and diabetes. They have diametrically opposite effect on the bladder, right? So when a person presents with CVA and diabetes and they have bladder dysfunction, I don't know what is affecting the bladder more, correct? So in neurogenic bladder, important to do urodynamics and not guess based on the location of the injury. That's my point, right? So you have lower motor neuron lesion. How is that defined? What is lower motor neuron lesion in the bladder?
Involvement of the sacral arc, sir, from the beyond the spinal cord to the bladder.
What about S2, 3, 4 injury? Is that still lower motor neuron lesion?
yes,
Yes,
sir.
sir.
Yes, sir.
Yeah.
Yes.
So
Yes, sir.
your first question was, your first answer was correct, and then you uncorrected yourself by just making peripheral in nerve injury. So it involves sacral cord and peripheral injury, right? So, and then you can have a mixed lesion. Where is mixed lesion most commonly present?
Multiple sclerosis.
Uncommon. They're almost always upper motor neuron lesion, but it can be.
Diabetes mellitus.
Diabetes is more lower motor neuron lesion, periphery. 17% will have bladder overactivity, but child, think of a child,
Diseases.
think of a child, myelomeningocele, right? That's very common, right? So important to think of different conditions. The most important part is to separate out what happens. We talked about cortex being primarily inhibitory, right? Pontine maturation center, coordination. And if the cord is sacral spinal cord or lower, the bladder becomes areflex, with or without changes in compliance. There's a difference in anterior horn injury and posterior horn injury. So if you have example of anterior horn injury is what? Peripheral nerve injury, anterior horn. Surgical injury occurs in?
Abdominoperineal resection.
Absolutely correct. And radical hysterectomies,
Yes.
right? As opposed to posterior horn injury. What is the clinical condition where posterior horn injury?
So diabetes mellitus.
Diabetes mellitus. Absolutely, 100%. Okay, so now this unmyelinated fibers, C fibers, are pain fibers that occurs with a UTI and also postulated to be a cause of interstitial cystitis. Usually dormant, but can become alive and stay active in some patients with IC. All right, here's a different listing, basically, of upper motor neuron lesion. Now, you have spinal cord, which can be MS as well as disc disease, Guillain-Barré, myelomeningocele. You have neuromuscular condition. This is predominantly a skeletal muscle involvement. And then you have peripheral nerves, which is pelvic plexus and diabetic neuropathy, right? But obviously there are combinations, right? We talked about CVA and diabetes, MS, Parkinson is aged related. You don't see this in young individuals often. So they have age related. So a male patient with Parkinson comes in, he has voiding dysfunction. You have to separate out the Parkinson effect versus the outlet obstruction, right? So it's important to try and separate the conditions out. Why is studying neurogenic bladder important? The most important, your job is to prevent deterioration of the upper tract, which is due to high pressure storage, poor emptying, or non-compliant bladder. How do you detect? If you're late, then hydronephrosis. If you're very late, renal failure. This used to be the most common cause of spinal cord injury patient dying in the past. Of course, most recently, that's not the case. Yet, episodically, in my camp situation, I see patients with blown upper tracts, which have not been evaluated at all, right? Simply by doing CIC, they could have avoided that. And then, of course, symptoms, not always present. Patient comes and tells you, I'm voiding normally. This normal is pushing urine out, which varies time to time, while the emptying is occurring. And of course, depending on this, why do stones occur in patients with neuropathic bladder more commonly? Spinal cord injury patient. Say that again.
Significant post-void residual urine.
That is correct. That's bladder stone. Why do they form renal stones?
Immobilization, hypercalciuria will be there.
Correct. So there is demineralization of bone due to inability to. All right, let's move on.
Detrusor overactivity.
Detrusor overactivity.
That is correct. All of you have prepared well. Okay, here's the patient now. Her chief complaint is urinary incontinence. She's 71 years of age. She has bothersome urgency frequency, voids 10 times daily, need to void. She's leaking, described mixed incontinence, both stress and urge. So a couple of history points here. When a person complains of the urgency frequency and voiding 10 times a day, my next question to them typically is, when you go to bed, how many hours can you sleep? And that answer makes a determination of bladder versus non-bladder dysfunction. If the person tells me they sleep 6 hours at a stretch without leaking, that's not a bladder condition, correct? That 10 times voiding frequently during the day. It would be uncommon in a patient like this who's leaking, right? So if she leaks with urgency, that is almost always a detrusor overactivity. Whereas urgency alone can be sensation driven. It doesn't have to be detrusor overactivity. So I have urgency to go. I go 10 to 12 times in a day and I sleep through the night. That person does not have a detrusor overactivity by definition, does not have a UTI by definition, does not have a bladder condition by definition. She's voiding by sensation, a feeling of going rather than needing to go, right? That is a way to separate out. But if the person tells me they leak with urgency, then that history becomes less relevant. The change of position, leaking, can sometimes present as stress incontinence, but that is a detrusor overactivity that's initiated by the act of getting up. As I'm getting up, I bear down, I bend forward to get up, so that pushing causes urine to enter the urethra and triggers the bladder to go, right? Occurs more in patients who are heavier. So she's getting up 4 to 5 times a night. She's in bed for 10 to 12 hours. This is long-term. She's had some sort of a mesh placed about 8 years ago. She had a sling done. Does not have hematuria, dysuria, pelvic pain. no measurable UTI, no vaginal discharge, no constipation, does not drink excessively, no history of stones. She has shuffling gait. She's had D4P3, obviously the Parkinson's disease. These are her medical situations. And she's had a bypass, colectomy, mid-urethral sling many years ago. She's on a few medications, Cinemet for the Parkinson, Aricept. All right, so her physical exam, mild memory deficit, tremor, shuffling gait, age-related changes in the vagina.
Post-wide residuals.
D, sir.
E.
You need all of it, right? You need a UAN culture to make sure there's no infection before you initiate workup. You need her post-wide residual, which is key in management. And ideally, you should do a standardized questionnaire. What's the standardized questionnaire in a woman? Everybody knows about the IPSS in a male. What do you use in a female?
There's a UAB symptom score, OAB symptom score, and
So the most standard or most commonly used is UDI 6 and IIQ 7. Yeah, 6 questions in the UDI. If you want to do a specific OAB study, then yes, OAB ICS has FLUTS. But those are more research oriented. But the most common clinical questionnaire used in general female population is UDI 6, and the IIQ assesses how that affects their quality of life, right? I'm particularly proud because UDI 6, IIQ 7 originated in Wake Forest many, many years ago, not by a urologist, by a social medicine person. All right, so creatinine is normal, or I'm sorry, it's slightly elevated with decreased GFR. She has minimal residual. She did not fill out the questionnaire.
Further workup with voiding diaries.
Right. So before, so standard when they come in, I tell them keep a diary, and I put them on this bladder training program. Fluid and bladder modification is basically a timed voiding and restricting fluid 2 hours before they go to bed, elevating their legs in the evening hours. And I tell them, keep a diary for 2 days, then go on this bladder training program and come back in 4 weeks where you're scheduled for urodynamics. If they've cured themselves, that means the bladder training alone helped. I also give them a prescription of medication to start in 2 weeks or 3 weeks if the training alone is not helping. So this way, by the time they've come back, they've gone through step 1, step 2. Now they're ready for urodynamics and step 3 for me, rather than multiple visits to me, which I can't afford to have so many appointments. So that's my style. You can do it differently. The guidelines ask you to go with lifestyle modification first, then with medications, increasing dose of medications, and then go on to urodynamics and stage 3 management. So what medications would you consider antimuscarinics or not in this patient? It's
We
a
can
yes or
consider
no.
antimuscarinics. Yes, sir.
Anybody else?
History. There was some
So she's 71, she has minimal PVR, she has urgency incontinence, 5-6 pads a day, day and night. Would you in addition to lifestyle modification and bladder management, would you consider use of antimuscarinics in this patient?
No, sir.
No.
Why not?
No.
This is
So
the
she has
cardiac-
Parkinson's disease. So she has pseudodysynergia, so she can go into retention.
So that's an incorrect reasoning. The answer was correct, but the reasoning is incorrect. So pseudodysynergia retention with antimuscarinic is not the concern. There is some reported literature in terms of Parkinson being worse with antimuscarinics, Parkinson's symptoms, plus age. She's beyond 65. So she has memory loss. She's already on Aricept. So you would not consider antimuscarinic in this lady. Because you have a choice, you can put her on beta-3 agonist. So 3 different things: age, memory loss, and Parkinson. All 3 would be a relative contraindication for antimuscarinics. So I went through that guidelines. Basically, you have, this is on the AUA website. This is related to OAB in terms of the history physical urine analysis, then going through patient education, behavioral treatment, pharmacological management, and then coming to the third line treatments. All right. Now, these are not neurogenic bladder guidelines. Those are different. All right. So here's the urodynamics. Read for me what's happening. So again, for orientation, this is bladder line, this is abdominal line, this is neck detrusor, this is EMG, this is voided volume or flow rate, this is voided volume, and this is filling volume. Is the study accurate? Let me ask in first part.
Study is accurate, sir.
Okay, so the filling is
I can
up
see
to
some
here.
sort of terminal diffuser overactivity is there, sir, before she's starting to void.
So first sensation, what's happening here? What is this?
Some amount of loss of compliance is there, sir.
Fully compliant bladder.
So when the pressure is rising like this and you're doing the study, how do you know it's not a contraction and a compliance? How can you judge?
There's no corresponding increase in the EMG activity.
No, during study, if you stop filling and the pressure drops, then that's compliance. If the pressure continues to mount, it's a contraction. That's how, while doing study, you can determine if it's compliance or not. All right. So here, now contraction is occurring at, I don't know whether you can read this. This is 365 or something like that.
355.
Right. So the capacity is adequate. Am I right?
Reasonable, sir.
Okay. So what's happening here?
Abdominal straining.
So she's straining a lot, right? She has enough detrusor activity, but she's frustrated by this firing of EMG. And the difference in DSD versus the, all right, we'll get to that. So how would you counsel this patient? The question should have better answered. What would you first ask the patient to do? Primarily, one of these 5.
To
Stop
relax.
valve body.
Right. So coaching the patient is important, that you're getting frustrated because you can't initiate voiding and you start helping by pushing. Resist that. Focus on pelvic floor relaxation actively rather than pushing as a means of overcoming that initial hesitation. So this happens a lot in Parkinson patients. They have initial hesitancy and they compensate for that. This is perhaps well known to you. It's more common after Alzheimer's. Again, patients are older, and all these are very big factors in managing them. It's very, of all the neurogenic situation, this is perhaps the hardest because the patient's physical ability, age, all that plays a factor. And in terms of managing them, you have variety of, they can't get to the bathroom. So simple changes that we manage in these patients is teaching them to wear clothing that can be easily pulled down and don't have to be unbuttoned. We keep a urinal or avoiding contraption easier or closer or commode next to them so they don't have to walk as much. And of course, teaching them how to improve their effort in urinating and then managing the bladder situation. So what happened here? All right, so voiding dysfunction is present at a high level of these patients, affecting quality of life. We've actually studied patients both before and after deep brain stimulation and compared them to patients who have intentional tremor, which can mimic Parkinson, but has no bladder influence, whereas the urodynamic finding of detrusor overactivity is the most common finding in these patients. The pseudodyssynergia, as was mentioned before by one of you, is not true dyssphincter and it's uncommon to have bladder areflexia in these patients. It's often misdiagnosed, and hesitancy is the most common complaint, particularly in male patients, and detrusor overactivity by percentage is more common. So urodynamically, I think I already showed you the patient. This is a classic picture diagram to show you detrusor overactivity. And the bradykinesia is what I talked about. Now, what happens is before they void, there's a delay in relaxation before voiding begins. So voiding is normal here between that period of increased dyssynergia. And Statskin talked about in determining patients, male patients with BPH, where you're going to do a TURP and they have detrusor overactivity, you want to know whether they're going to respond to the relief of obstruction. They become more incontinent after TURP, is assessing volitional control of their pelvic floor. If they had volitional control of their pelvic floor on the EMG, then they remained continent. If they had no control, most of them became incontinent after. So there's one way to differentiate. Today, because of less invasive options, we have many more choices before we do a TURP on patients like this. So we would often do a iTind, which is a temporary stent, reversible, or Urolift, or something else before we would consider doing a TURP in a patient with Parkinson. All right, any questions thus far before we move ahead with a third type of scenario? How are we doing with time? I'm almost to the full hour.
D.
Stop the study and decompress the bladder.
Shall I continue or
Yes,
should I
sir.
start?
D.
Okay, so here, what was the answer? I'm sorry.
Please stop the study and decompress the
The
bladder.
study as quickly as possible.
Very good. You guys have all passed today. All right, what's the answer here?
40, sir.
Answer is B, correct. So here's a patient with spinal cord injury. Bladder is managed with a urethral catheter. You see mild hydro on both sides. What is the answer?
Compliance would be
Compliance.
Compliance.
Right. It could be any one of those three, right? If DSD exists with reflux, then yes. Is it compliance? Yes, over a period of time, bladder compliance can be lost. And is it supravesical obstruction? So how would you separate? and we separate by doing a renal scan with a catheter in the bladder. And if you do that, then you can see that there is obstruction at the supravesical level, which is thickening of the bladder, causing a UVJ obstruction. So poor bladder compliance, hydrourethronephrosis, there are neurogenic causes and non-neurogenic causes, typically upper motor neuron or lower motor neuron. Here would be DSD, or an anterior horn injury that causes denervation and fibrosis, or from radiation. All of these will affect bladder thickening, resulting in a UV obstruction. So when a patient presents with a hydro, you decompress the bladder, the hydro disappears, then it's the bladder or the outlet. If the hydro does not disappear, then renal scan confirms that there is a UV obstruction, and treating that patient with Botox, CIC, suprapubic tube won't help. You need to do a supravesical intervention or put stents across the UVJ and treat the bladder. Neurogenic bladder dysfunction, your treatment management plan, the goal is to lower bladder pressure, protect the upper tracts by improving the compliance, improving the emptying. Symptom alleviation comes second. That's the patient's main concern. Your concern should be here. And by delaying or ablating involuntary contraction or improving compliance, UDS is what determines findings for me in terms of how to. This is from the AUA guidelines. I think Dr. Chawla included that in the reference paper today. This is trying to assess low risk versus unknown risk patients, and then low risk, you just need to initially assess and then manage them. It requires less observation, less UDS, etc., whereas moderate to high risk patients require much more assessment to prevent upper tract damage. This is, available on the guidelines paper. I think that's ending. Yes. Sorry, I took a little longer than planned, but almost to the hour.
Thank
Yes,
you
sir.
very much, sir. It was very, very enlightening. The neurological conditions, though it works like a mathematics, but always poses challenges to students when they actually face exams. It is more of a stressful situation. So you have covered it very nicely, and
I try very hard not to do memorizing. Rather than that, you understand logically what's happening. Then logic helps you to reason out what's happening.
Very true.
So Dr. Chawla is there in the group, sir. Chawla, sir.
Honor to have him. Which part of the country is he in today? He's always on the road.
I think he has to travel to Hyderabad.
चला साहब माइलेज आपका frequent flyer mileage balance तो काफी होगा.
Sir, I want to ask you one question. Every time I find that your slides have different animation, and you try and take efforts in making it very bright, and like it's the animation is very good. You do the slides on your own, sir? Or
No, my resident fellows, others help a lot. So no, I can't take credit. Most of the writing is mine, but putting together the pictures from like radiology and all that, that's easy to incorporate. But the line diagrams and animation are often borrowed or made by somebody else. No, I'm not artistic. I just collect from various sources.
Bobby, there is a question in the chat box.
Sir, actually, you explained this. They have asked question again that how do you differentiate poorly compliant bladder and bladder which is contracting in UDS? That's
Yeah,
the time when
so
you actually stop to filling
it
and
depends.
assess.
You can't differentiate after the study. It's during the study. If you're doing the study yourself and you stop filling the bladder in a patient with poor compliance, the bladder pressure will drop because it's a relationship of filling rate versus acceptance by the bladder. So if you stop filling, the pressure will drop. But if the bladder is contracting, it doesn't relate to the filling, so it'll keep contracting and the pressure will keep going up.
So there was one more. Does the manifestation in CVA overlap with diabetes? If so, what will be UDS findings?
So, like I said, you can't predict. It's a predominant finding. If the stroke, if you're studying within the first 3 months, it's unlikely to show overactivity. If you study 3 months or later, overactivity becomes more prominent. The diabetic patient, if they have long-standing diabetes and associated peripheral neuropathy, you may find that bladder is acontractile or the hypocontractile. That's based on peripheral neuropathy. So only diabetes alone, a history which is well managed, and a CVA will have predominant CVA effect, whereas a person who has long-standing history of diabetes with peripheral neuropathy and had a stroke, their bladder may be more diabetic type. That means they'll have more chance of retention. So that's why I said you can't guess. You have to do a UDS and find out what the findings are.
Ma'am, there are no more questions.
Yes, Bobby.
Can you conclude, madam?
Yes, sir. Yes.
From your side, please.
Yes, so we are definitely happy that you have continued this year also for the smart learning course, and I would take your suggestions and we'll definitely make a survey or make a questionnaire followed by your presentations, and I will pose it to different student groups, and I request Kashi and all the others who have logged in here that if you want Dr. Gopal Badlani sir to discuss something specifically.
Yeah, again,
go.
it doesn't have to be me. What you should consider on a Survey Monkey or as a suggestion is, format. Say you want a straight lecture versus broken up like Q&A like we did today. It's a mixed. It's not only Q&A. Whereas you were given pre-learning objectives so that you prepared for this talk, it's always helpful to give you in advance notice what is it going to be about. If you read a little bit about it or the guidelines, then it helps you a lot to learn that day. At least that's my experience. And then you say, well, this is what we lack. This is what we should learn. It doesn't have to be me. I can get you other speakers to speak on a topic. So you prepare specific topics that you consider deficient in your teaching, learning, etc., or you see more commonly where there's controversy. It could be anything, whether it's a surgical technique, whether it's something, for me to be able to get a speaker is not difficult.
Yes, so that's a very nice offer to us, and I'll get in touch with the student groups, sir. And we have a few student groups, and I'll get back to you. And also
very important in terms of evaluation, whether it's me or someone else, you must have a proper assessment technique for the learners so that as part of your ISU, you can maintain, we did needs assessment, this was the need, we did the course, and this is the evaluation of the learning so that next time around we could do something better.
Yes, sir. I'll just definitely take that suggestion and work on it. And I'll get back to you with the suggestions from students. And we do look forward to your next lecture with us. And I think so this format was nice, but I'll definitely take a feedback from the students and ask what they would like, because you could see them, they were responding on the chat box. They were answering together. And so I think they definitely wanted more of your questions. And I think most of the time they were right.
Yeah, I'm very impressed with all their
Yeah.
learning, and I was wondering whether I need to teach anymore. I mean, they already know the answer. Good,
I
good
think
to
they
see you
were
all.
Dr. Chawla students also, so they must have got an extra dose on urodynamic reading. Anyway, thank you very much, sir, and thanks for your time and taking out time for us. We really appreciate it.
Okay.
I also would like to thank all the students who participated and our USI leadership and Bobby and Dr. Chawla for coordinating today's session. Thank you very much and good night.
Good night.
Thank you very much, ma'am.
Good night.
Thank you very
Sir.
much.
Thank you.
Good night.
Thanks.